Good evening. Uh, Good evening, Tilly Heavens. Good evening, Chakravarti. Okay. So I hope I'm audible. Hi, Dr. Siraj. Am I audible? Hi, Chiefs. Abhijit. So today's session, thank you, Sneha. So it's a NEET PG Biochemistry Must Know Images session. And in this session, I will be telling you about few practical aspects of biochemistry which can be asked as MCQs. For example, biochemical test-based images or investigation-based images, and then a few questions based on genetics. And this will be a short session. Thank you, all of you. And before we start the session, let me tell you a few facts about, good evening, Vishnu. I will be telling you a few facts about Unacademy plans. So first, it's about All India mock test. Do attempt this test. It is on April 17th and the time is at 9 a.m. And the reason behind why I want you to attempt this test is, as always, you would get your score. But apart from that, you will be able to benchmark your performance because you'll also be given a rank prediction. So based on your score now, you'll be getting a rank prediction. So do attempt this test. And to enroll yourself for this All India mock test, if you need a code, you can use my code C Shanmugapriya. And just now we have started MBBS Prof 1 course, and in this course, anatomy, physiology, biochemistry, all three subjects will be dealt in detail. And this will be integrated with clinical subjects, and students will also be taught about practicals, how to write an exam. So it will be a holistic approach that we have adopted for this. So you can recommend this to your juniors. And the cost of this course would be, for 3 months it would cost 5,500, but now the pre-launch price would be 4,950. And we have Unacademy Lite subscription which is new, and this night subscription will entail you to write all subject-wise tests, full-length mock test and grand tests. And currently what is new about plus classes, all subscribed classes, is for every session, after every session there will be a practice paper which you can attempt to understand how much of the subject you have understood from the session. And special class features include interactive live sessions. You will be able to participate in polls, and using the raise a hand option you will be able to interact with the educator one-on-one, and you can get your doubts clarified real time. Good evening, Ashika. And apart from these live and recorded sessions, there are multiple free tests which are happening on the platform. There are subject-wise tests, as I told you, educator curated test series, previous year question series. So try to attend as many tests as possible, because that will help you understand where you stand. Plus subscription gives you access to both live and recorded classes conducted by top educators, and it also gives you access to a question bank with 25,000 plus clinical case-based MCQs. When will high yield session resume? I have already started, Sangeeta. We are doing it now. Tomorrow, you mean today there is a NEET PG MCQ session. Tomorrow we will be having genetics continuation. So it also gives an access to a question bank with 25,000 plus clinical case-based MCQs. Iconic subscription, as you all know, gives you will enable you to access not only Unacademy platform but also PrepLadder platform. And if you have either a plus subscription or iconic subscription, then you can access all the structured courses which are happening on the platform. If you're an FMG aspirant, there is an FMG high yield revision and MCQ batch which has just started, or which will be starting on April 13th. The duration of this course is 1 month. And if you're a NEET PG aspirant, there is NEET PG 2022 high yield theory revision batch, and the duration of this course would also be 1 month. And in both these batches, all 19 subjects will be discussed. All high yield MCQs will be discussed. You will also have an access to grand tests. And there is a doubt clarification batch. The duration of this batch is 1 month. And in this 1 month duration, every educator is provided approximately 2 hours. And in these 2 hours, you can meet the educator. You can get all your doubts clarified. That can be multiple ambiguous questions for which you have multiple answers. You might have dicey answers in mind. So such doubts can be clarified if you participate in this batch. And these are our toppers in the latest FMG December 2021. The highest was 217, closely followed by 209. And this is the current NEET PG subscription plan. For a minimum subscription for 2 months, that would cost you 7,650. And this cost is inclusive of 10% discount. To avail this 10% discount, you can use any educator's code. My code is my name C Shanmugapriya or Biochem Life. So that's all about Unacademy plans. Okay. So now let's start discussing these image-based MCQs. This is the first question for you all today. It is about electrophoresis. As I told you, it's more of techniques and methods. So lipoprotein electrophoresis of a patient presenting with chronic kidney disease, corneal opacity and low HDL is provided here. The band identified as A. Do you see a letter A here? The band identified as A and the disorder is. What do you think is the right answer? Just make a guess. Would it be choice A, B, C or D? M band and multiple myeloma, chylomicron and type 1 hyperlipoproteinemia. Always try to exclude choices. Yeah, whenever it's an image based question or if it's a case based MCQ, even if you think you don't know the concept, try to exclude choices. Okay, many of you think it's choice A. Sangeeta and Adnan. Shagufta thinks it's B. Aruna Devi thinks it's A. Dr. Siraj thinks it's A. So I would say that you should exclude choice A first. Why do you have to exclude choice A? Because M band of multiple myeloma, is it seen in lipoprotein electrophoresis or is it seen in protein electrophoresis, all of you? Yeah, M band of multiple myeloma. What is M band in the first place? Yeah, M band is nothing but monoclonal antibodies. Monoclonal antibodies will be seen in the gamma region of protein electrophoresis. But what does the question say? The question says it's lipoprotein electrophoresis. So can we exclude choice A straight away? Yeah, so this is not choice A. Now look at choice B, chylomicron and type 1 hyperlipoproteinemia. So in type 1 hyperlipoproteinemia, it is otherwise called as familial chylomicronemia syndrome, wherein as the name indicates, chylomicron level will be elevated. Okay, when chylomicron level is elevated, you might find a band here. But what do you think will be the clinical feature? When there is chylomicronemia syndrome, when chylomicron level is elevated, which lipid concentration will be high in the plasma? Which lipid concentration will be high in the plasma? Triglyceride concentration will be high in the plasma because chylomicron carries triglycerides. And whenever there is hypertriglyceridemia, are you going to find chronic kidney disease, corneal opacity and low HDL? No. Hypertriglyceridemia will present as eruptive xanthomas. Yeah, what will it present as? It presents as eruptive xanthomas, recurrent pancreatitis. So had the history been recurrent pancreatitis, eruptive xanthomas, then you can suspect choice B. But the history is totally different, right? They have not mentioned anything about xanthoma. They have not mentioned anything about pancreatitis. And that is why even if I know nothing about lipoprotein electrophoresis, I would not suspect B. Okay. Now look at choice C, LDL and type 2 hyperlipoproteinemia. What is type 2 hyperlipoproteinemia? Type 2 hyperlipoproteinemia is nothing but familial hypercholesterolemia. It is nothing but familial hypercholesterolemia, in which condition when cholesterol level is elevated, you will find tendon xanthomas and accelerated atherosclerosis. Whenever there is hypercholesterolemia, what will you observe as features? Tendon xanthomas and accelerated atherosclerosis. But have they given anything related to that? No, which means what can be excluded? It is not choice C, it is not LDL and type 2 hyperlipoproteinemia. So just by exclusion, what do you think is the right answer? Yeah, very good, Meena Krishna. There are some of you who have chosen it as very good cheeks. Excellent. So what is the answer? The answer is choice D, which is lipoprotein X and complete LCAT deficiency. Okay, so now I'm going to give you an introduction to lipoprotein electrophoresis and then I will tell you why is it lipoprotein X. I want you to closely follow this. So usually lipoprotein electrophoresis is done on a glass slide. And on this glass slide, towards one end of the glass slide, you apply the serum. Yeah, you apply the serum, lipoprotein of which has to be separated. Can you see that here? Yeah, towards one end of the glass slide, you apply the serum, lipoprotein of which has to be separated. And then you connect this glass slide to an electrical supply. Actually, what we do is we place this glass slide in an electrophoretic tank, and we fill this electrophoretic tank with an alkaline buffer. If you're asking me why are we dropping it in an alkaline buffer, only in an alkaline pH all these will get negative charges. So all your lipids are now negatively charged. Now you connect this glass slide to an electrical supply in such a way that close to the point of application is connected to a negatively charged electrode. Can you see that here? Yeah, close to the point of application is connected to a negatively charged electrode. The opposite side is connected to a positively charged electrode. So when you switch on the electric current, because all your lipoproteins are negatively charged, they start moving towards positively charged electrode. Yeah, the migration here is affected by what? Because they are negatively charged, they are moving. So migration here is affected by the number of negative charges they carry. And do you all know that HDL has got the highest negative charge? Even otherwise, do you know that HDL has got the highest phospholipid content and the highest protein content? Tell me yes or no. Yeah, HDL has got the highest phospholipid content and the highest protein content. Phospholipids and proteins will give them the highest negative charge. So which lipoprotein migrates the fastest? The lipoprotein which migrates the fastest would be HDL. So the band that is present farthest from the point of application is going to be alpha band. What do you call it as? You call it as alpha band, which is nothing but HDL. Okay, and in quite contrast to this, your chylomicron, because chylomicron size is very large, it cannot migrate along the gel. So chylomicron will be present close to the point of application. So close to the point of application, if you see a band, what is that band? Close to the point of application, if you see a band, that is called as chylomicron band, if at all it is present. Yeah, why am I saying if at all it is present? Because usually lipoprotein electrophoresis is done on a fasting sample. Will a fasting sample have chylomicron? Don't you all know that chylomicron is a product of dietary triacylglycerol? So in a fasting sample, you cannot expect chylomicron. So in a normal person's sample, you won't see any band at the point of application. You won't find a chylomicron band. But if you see a band at the point of application, then you can suspect lipoprotein X. Yeah, at the point of application, if you see a band, what should you suspect? You should suspect lipoprotein X. And lipoprotein X is a lamellar lipoprotein which is seen in LCAT deficiency. Can any one of you type it in the chat box? What is LCAT? What do you think is LCAT? Any idea? Can you abbreviate LCAT? LCAT is lecithin cholesterol acyl transferase. What is LCAT? LCAT is lecithin cholesterol acyl transferase. We don't have time to discuss what exactly it does. All that I want you to know is LCAT converts discoidal HDL. Yeah, LCAT converts discoidal HDL to spheroidal HDL. So tell me, what is the function of LCAT? LCAT is to convert discoidal HDL to spheroidal HDL. So what happens in LCAT deficiency? In LCAT deficiency, spheroidal HDL concentration will be very less. Yeah, do you remember in the history they had given you HDL value is very low. And don't you know that HDL function is in reverse cholesterol transport? What is the main function of HDL? It is involved in reverse cholesterol transport, wherein HDL collects cholesterol ester and phospholipids from extrahepatic tissue membranes and it dumps it in liver. That is what we mean by reverse cholesterol transport. So when there is no HDL, there is no reverse cholesterol transport. So cholesterol esters accumulate everywhere. And when cholesterol esters accumulate in cornea, that causes corneal opacity. And that is why it is called as fish eye disease. Corneal opacity, that is why it is called as fish eye disease. Okay, and when cholesterol ester accumulates in the membranes of RBCs, When cholesterol ester accumulates in the membranes of RBCs, it undergoes lysis. And that is why it is fish eye disease plus hemolytic anemia. Very good, cheeks. Fish eye disease plus hemolytic anemia. And they also present with chronic kidney disease. Video quality is not good. Do you all agree with that? Is the video quality not good? When I see, I think it's good. Other students, can you please comment on that? Yeah, I think my side it's perfect. Probably your phone resolution is not correct. Yeah, try to check it from your end because I have a perfect connection, perfect settings. In my mobile it is correct. Okay, so can we go ahead? So what do you expect in LCAT deficiency? In LCAT deficiency, there is low HDL concentration, point number 1. When there is low HDL concentration, there is no reverse cholesterol transport. So cholesterol esters accumulate in cornea, causing corneal clouding. That is why it is called as fish eye disease. And when it accumulates in RBC membrane, it causes hemolytic anemia and chronic kidney disease. The reason for chronic kidney disease in LCAT deficiency is, in LCAT deficiency, discoidal HDL accumulates. And this discoidal HDL on accumulation will get a lamellar structure. Yeah, it gets a lamellar structure that is called as lipoprotein X. And this lipoprotein X on one hand forms a band at the point of application. On the other hand, it accumulates in kidney. And that elicits an antigen antibody reaction, and that initiates the process which leads on to chronic kidney disease. So that's about LCAT deficiency. Okay, and you also find lipoprotein X in obstructive jaundice. So tell me, what are the two causes of lipoprotein X? Lipoprotein X is either because of LCAT deficiency or it is because of obstructive jaundice. So this is about the HDL band or alpha band and about the band that is present at the point of application. And then after this chylomicron band, if you see a band, that is called as beta band. Yeah, what do you find? That is called as beta band, and this beta band is made up of LDL. And after beta band, we call it as pre-beta band. Why am I calling it as pre-beta band? Because it is moving ahead of beta. Do you understand this? That's called as pre-beta band, and that is made up of VLDL. Yeah, that is made up of VLDL. And usually you find remnants. Usually you find remnants somewhere here. Can you see that here? The gray zone that I've shown here. The gray zone that is shown here is nothing but remnants. And usually, in a normal person, this gray zone will not be seen because remnant concentration in a normal person is not that good or that high to form a band. But if you see a band here, yeah, if you see, very good all of you, but if you see a band here, it means it is called as remnant disease. Yeah, it is called as remnant disease, which is nothing but type 3 hyperlipoproteinemia. So in type 3 hyperlipoproteinemia, what do you see? You see a band that is close to the beta band, causing a broad beta. So when will you see a broad beta? Broad beta is seen in type 3 hyperlipoproteinemia. And this type 3 hyperlipoproteinemia is otherwise called as remnant disease, when you see a broad beta band. Clear? So as far as lipoprotein electrophoresis is concerned, there are only 5 facts that you need to remember. So what are the 5 facts that you need to remember about lipoprotein electrophoresis? The farthest band from the point of application is the alpha band, and alpha band is nothing but HDL. The band that is present at the point of application is chylomicron band, and usually chylomicron band is undetectable. But if you see a band at the point of application, you will have to suspect what? At the point of application, you will have to suspect lipoprotein X. Lipoprotein X is a feature of what? LCAT deficiency and obstructive jaundice. Yeah, LCAT deficiency and obstructive jaundice. After chylomicron band, close to the point of application is beta band. Beta band is made up of LDL. And the band that moves ahead of beta band is called as pre-beta band, which is made up of VLDL. Usually remnants are seen migrating along with beta, but normal person remnant concentration is too low to form a band. But in a person with type 3 hyperlipoproteinemia, you find a broad beta. Yeah, you find a broad beta because of remnant accumulation. Okay, so if you know this, that is more than enough. Now, can you all look at the image? In the image, do you see a negative sign here? Negative sign is where the point of application is. So, at the point of application, do you see a band in the patient sample alone? Normal person, you don't see any band at all. In the patient, there is a band. So, at the point of application, if you see a band, what is your answer? Harshavardhan, what should I repeat? I told you so much. What should I repeat? So, at the point of application, if you see a band, what are the possible causes? The possible causes is chylomicron elevation, or it is lipoprotein X because of LCAT deficiency. Okay. Good. So, this is the next question. A 10-year-old known patient of type 1 diabetes presents with unconsciousness, dehydration and fruity odor of breath. So these are all clues. Yeah, these are all clues that are given to you. The moment you see fruity odor, what will you suspect? Fruity odor is diabetic ketoacidosis because acetone breath, acetone gives the fruity odor. Her blood pH is 7.33. So your suspicion of diabetic ketoacidosis is reinforced. Why is it reinforced? Because what is the normal pH, all of you? Very good. Diabetic ketoacidosis. Excellent, Aruna Devi. Yes. So what did I tell you? pH is normal pH is 7.36 to 7.44. In this case, it is acidotic. So diabetic ketoacidosis. So the clinician suspects diabetic ketoacidosis and orders for a bedside test for detecting ketone bodies. The results are shown by the side. Yeah, always have a look at the image. In the image, the first tube is positive control. Yeah, the first tube is positive control. The second tube is patient's urine. So tell me, is this test positive or negative? If there is a purple ring, it is positive. Here you don't see a purple ring, so the test is negative. The test performed and the reason for the result is. So first tell me, what is the test? Yeah, what is the test? Prathamesh thinks ketone bodies are absent. Tell me, what is the test name, please? Vairam, good evening. The test is Rothera's test. Because you know it is Rothera's test, which choice have you excluded? Very good, Meena Krishnan. Yeah, which choice have you excluded? Because it's Rothera's test, we have excluded choice C. It is not Fauchett's test. So can you tell me what is Fauchett's test used for? Fauchett's test is used to detect bile pigments. Okay, Fauchett's test is used to detect bile pigments. This is not Fauchett's test. We know it is Rothera's test. Then tell me, is it positive or negative? You said it is negative. So which choice have you excluded? It is not choice A. Right? It is not choice A. So we are left with choice B and choice D. Rothera's test is negative. Beta hydroxybutyrate does not answer the test. Rothera's test is negative. Low availability of oxaloacetate. So what is the right answer? The best answer would be Rothera's test is negative because beta hydroxybutyrate does not answer Rothera's test. Okay. So I'm going to quickly tell you the pathogenesis of diabetic ketoacidosis. Then I will tell you what does it mean. Okay. So listen to this, Karthika. I understand that you have chosen choice D. I will tell you this, then you will understand why it is choice B. Okay. So diabetic ketoacidosis, what is the basic pathophysiology? It is mainly because there is low insulin. Yes or no? In diabetic ketoacidosis, everything is because there is low insulin. When there is low insulin, what will happen to hormone sensitive lipase? Hormone sensitive lipase in adipose tissue gets stimulated. For those of you who do not know what is hormone sensitive lipase, I keep telling about this. So your adipose tissue has got hormone sensitive lipase. And the function of this hormone sensitive lipase is to act on triacylglycerol of adipose tissue to cleave it to give glycerol and fatty acid. Do you all understand this? What is the function of hormone sensitive lipase? Where is it present first? Hormone sensitive lipase is present in adipose tissue when its main function is to act on the adipose tissue triacylglycerol to cleave it to give glycerol and fatty acid. So tell me, is it a catabolic enzyme or an anabolic enzyme? Because it cleaves triacylglycerol, it's a catabolic enzyme. In that case, what do you think is the effect of insulin on hormone sensitive lipase? Insulin is an anabolic hormone. So insulin inhibits hormone sensitive lipase. Very good. Insulin inhibits hormone sensitive lipase. In diabetic ketoacidosis, when there is low insulin, there is no inhibition of hormone sensitive lipase. So there is excessive peripheral lipolysis. In a patient of type 1 diabetes, there is excessive peripheral lipolysis. So adipose tissue triacylglycerol is cleaved to give glycerol and fatty acid. And both these glycerol and fatty acid will leave adipose tissue, will reach the circulation. And through circulation, both glycerol and fatty acid will reach the liver. Tell me what happens in the liver. Yeah, so all fatty acids enter liver. Tell me what happens in the liver. In the liver, the fatty acid will be oxidized. Don't you all know that when fatty acids get oxidized, you get acetyl-CoA? Yes or no? When fatty acids get oxidized, it gives rise to acetyl-CoA. And in a normal person, the acetyl-CoA that is formed will get into citric acid cycle. Yeah, in a normal person, acetyl-CoA will get into citric acid cycle. But for acetyl-CoA to get into citric acid cycle, won't you need oxaloacetate? Won't you need oxaloacetate? Yes, we need oxaloacetate. But in a patient of diabetic ketoacidosis, will oxaloacetate be available? Oxaloacetate will not be available because all the oxaloacetate in the liver would have got used for gluconeogenesis. Yeah, all the oxaloacetate would have been used for gluconeogenesis. Why gluconeogenesis? Because the person is diabetic. If the person is diabetic, there is no insulin. There is excess glucagon action. Glucagon action will stimulate gluconeogenesis. And for gluconeogenesis, all the oxaloacetate will get used up. So acetyl-CoA is not able to get into citric acid cycle. That is when acetyl-CoA accumulates. Yeah, because acetyl-CoA is not able to get into citric acid cycle, acetyl-CoA accumulates, and this acetyl-CoA condenses to form ketone bodies. Are you all clear about this? When acetyl-CoA accumulates, acetyl-CoA condenses to form ketone bodies. And the first ketone body that is synthesized is acetoacetate. Yeah, which is the first ketone body that is synthesized? It is acetoacetate. So this is called as a primary ketone body. Yeah, this is called as a primary ketone body. And this acetoacetate on spontaneous decarboxylation will form acetone. And this acetone is the reason for fruity breath. Yeah, this acetone is the reason for fruity odor in the breath. Whereas in the presence of beta hydroxybutyrate, acetoacetate gets converted to beta hydroxybutyrate. And for every conversion of acetoacetate to beta hydroxybutyrate, you use 1 NADH. Yeah, for every conversion of acetoacetate to beta hydroxybutyrate, you use 1 NADH. And in diabetic ketoacidosis, in acute diabetic ketoacidosis, it is something which is happening in the background of excessive fatty acid oxidation. And every time fatty acid gets oxidized, there is high NADH generation. And this high NADH generation will convert every acetoacetate that is formed to beta hydroxybutyrate. Do you understand this? Every acetoacetate that is formed in acute DKA will get converted to beta hydroxybutyrate. So in acute diabetic ketoacidosis, which is the major ketone body that is getting excreted in urine? In diabetic ketoacidosis, acute condition, which is the major ketone body that is getting excreted in the urine? It is beta hydroxybutyrate. And this beta hydroxybutyrate will not answer Rothera's test. Rothera's test is answered only by acetoacetate and by acetone. And that is why many a times in acute conditions of DKA, Rothera's test will be negative. And why did I give you this question? Because you are going to be future clinicians. When you become future clinicians, if you see Rothera's test to be negative, do not think, okay, it's not DKA. Many a times in acute conditions, Rothera's test will be negative because in acute DKA, the ketone body that is excreted is beta hydroxybutyrate, which will not be answered by Rothera's test. Does that clarify all your doubts? So what is the answer? Rothera's test is negative because beta hydroxybutyrate does not answer this test. Okay. So this is the next question. Identify the technique that is shown in the image and what is the parameter that is estimated using this technique. Okay, so do you see the image? Yeah, and in the image, do you see that there are two phases? One is a mobile phase. Can you see that they are pouring something on the top? So there is a mobile phase. Is there anything to do with GLUT4 and diabetes? Yes, dental Q. Diabetes is insulin deficiency. Only in the presence of insulin, GLUT4 gets upregulated. So in diabetes, GLUT4 is downregulated and GLUT4 is something which is present in adipose tissue. So without GLUT4, no glucose uptake into adipose tissue. That is another reason for excessive peripheral lipolysis. Okay. So do you see a mobile phase? They are pouring on something and that is moving on the column. So there is a mobile phase and there is a stationary phase. So whenever you see a mobile phase and a stationary phase, it means it is chromatography. Do you all understand this? It is chromatography. Which means what are the choices that you have excluded? What are the choices you have excluded? It is not electrophoresis, it is not potentiometry. So what are we left with? We are left with cation exchange chromatography and affinity chromatography. Prathamesh has answered it as choice C, affinity chromatography. This is not affinity chromatography because do you see a magnified view of the beads? Yeah, B and D are excluded. Do you see magnified view of these beads? And do you see negative charges on the bead? Which means the stationary phase is negatively charged. Whenever the stationary phase is negatively charged, when you pour the complex protein mixture, what alone will be held back onto the stationary phase? When the stationary phase is negatively charged, when you pour the complex protein mixture, what alone will be held back on the stationary phase? Only positively charged proteins will be held back onto the stationary phase. So do you see that the stationary phase is holding cations? Yeah, what is it doing? It is holding cations. If it holds cations, what type of chromatography is it? It is called as cation exchange chromatography. Do you all understand this? It is cation exchange chromatography and that is the best method that is used for HbA1c estimation. Reason is your glycated hemoglobin is more positively charged. Yeah, your glycated hemoglobin is more positively charged than the other forms of hemoglobin. So after lysing the sample, when you pour the hemolysate, when all hemoglobins come down the stationary phase, only positively charged glycated hemoglobin will be held on to the stationary phase. Every other hemoglobin will come down. And then you measure how much is held back and then you give the value. Okay. So tell me what would be the best method for HbA1c estimation. For HbA1c estimation, you can use both cation exchange chromatography and affinity chromatography. But all the values, all reference values, all treatment guidelines, they are all based on the values that were obtained from cation exchange chromatography. And that is why which is considered as the reference method. The reference method is cation exchange chromatography. Is that clear? Yeah. So from where did we start? We started with saying there are two columns. Yeah, there are two phases, stationary phase and mobile phase, which means it is chromatography. There is a negative charge which holds cations. So it is cation exchange chromatography that is used for HbA1c estimation. Okay. So a person gives a urine sample for a routine screening test. Benedict's test result is as follows. So you have been given Benedict's test result. This is control, this is urine. Okay, so is it positive or negative, all of you? You know, Benedict's test is a test that is done to detect reducing substances. It is a test that is done to detect reducing substances. If it is positive, you know that there will be a color change from blue to a series of colors. From blue it becomes green or yellow or orange or red, and you know the color will depend upon the concentration of the reducing substance that is present in the given solution. So tell me, is it positive or negative? Very good, all of you. I am happy that you have all given the right answer. So it is positive. So which of the following can be a cause? I mean, all of the following can be a cause except. So what is the right answer? As all of you have answered, it's multiple myeloma. Because in multiple myeloma in urine, all that you can detect is Bence-Jones protein. In multiple myeloma in urine, all that you can detect is Bence-Jones protein, and that is not a reducing substance. Otherwise, tell me what are the reasons? Yeah, what are the reasons for reducing substances to be found in urine? Causes can be physiological causes and pathological causes. Yeah, physiological and pathological. And the only physiological reason for reducing sugar to be found in urine. Yeah, the only physiological reason for reducing sugar to be found in urine is pregnancy. Yeah, pregnancy or lactation. Because in both pregnancy and lactation, you know the mother will be synthesizing lactose, and lactose can be excreted in urine. And lactose is a reducing disaccharide. Do you all know that? Yeah, lactose is a reducing disaccharide. Can anybody answer me what is lactose made up of? I've told you this so many times in the special class. Lactose is made up of what? Galactose and glucose. Okay, lactose is a reducing disaccharide which is made up of galactose and glucose, and the only disaccharide that can be found in urine is lactose, which is seen in pregnancy and lactation. Okay. Now, what are the pathological reasons for reducing sugar to be found in urine? The reducing sugar can be number 1, glucose, right? Number 2, it can be fructose. Number 3, it can be galactose. Sometimes it can even be pentose, right? So, what are the reducing sugars that can be found in urine? It can be glucose, fructose, galactose or pentose. So tell me, what are the conditions wherein glucose is found in urine? I want the chat box to be active, please. What are the causes for, which is the most common cause for glucose to be found in urine? It is diabetes mellitus. Very good, Prathamesh. I am happy that you remember. Yes, sucrose and trihalose are non-reducing disaccharides. Good. So what are the causes of glucose to be found in urine? Most common cause would be diabetes mellitus. Arpita, galactosemia, it is not glucose. Okay. Yeah, diabetes mellitus, or it can be because of renal glycosuria. What is renal glycosuria? For any reason, if the proximal convoluted tubule is not able to reabsorb glucose, for any reason, if the PCT is not able to reabsorb glucose, glucose will be found in urine. And we call it as Fanconi syndrome, right? Most commonly, it is Fanconi syndrome, or even otherwise, you have Fanconi-Bickel syndrome, GLUT2 transporter defect. Very good, cheeks. Excellent. I'm really happy that you all remember this. So, renal glycosuria, it can be Fanconi syndrome or Fanconi-Bickel syndrome for any reason if PCT is not able to reabsorb glucose. Or it can be alimentary hyperglycemia. Yeah, what is alimentary hyperglycemia? For any reason, if there is increase in the rate of glucose absorption along the intestine. Yeah, for any reason, if there is increase in the rate of glucose absorption along the intestine, in the immediate postprandial state, there will be a rapid absorption of glucose and there will be a steep increase in plasma glucose. And the steep increase in plasma glucose sometimes even crosses the renal threshold. Can anybody tell me what is the renal threshold for glucose? Yes, Prathamesh. What is the renal threshold for glucose? It is 180 milligram per deciliter. So the renal threshold for glucose is crossed and so it is found in urine. Yeah, so that is called as alimentary glycosuria. Example for alimentary glycosuria is thyrotoxicosis. Example for alimentary glycosuria is thyrotoxicosis, because in thyrotoxicosis, thyroxine causes upregulation of GLUT transporters across enterocytes. Yeah, and that is why in thyrotoxicosis, in the immediate postprandial state, there will be glycosuria. So can you all tell me what are the 3 causes of glucose to be found in urine? Most common would be diabetes, or renal glycosuria, or alimentary glycosuria. Okay. Now what are the causes of fructose to be found in urine? Fructose can be found in urine in essential fructoseuria or fructose intolerance. So quickly tell me, what is the cause of essential fructoseuria? Fructokinase defect causes essential fructoseuria. Fructose intolerance is because of aldolase B defect. Yeah, all of you memorize it. Essential fructoseuria is because of fructokinase defect. Fructose intolerance is because of aldolase B defect. So in all these conditions, fructose can be found in urine. When will galactose be found in urine? Galactosemia. Yeah, here you know classical galactosemia is because of galput deficiency. Classical galactosemia is because of galput deficiency. And pentosis can be found in urine in essential pentoseuria. So these are the pathological causes for reducing sugar to be found in urine. So having understood this, does SGL2 inhibitor also come under renal? Yes, you can have that. Good question, yes. Okay, so now tell me the answer for this question. Will reducing sugar be present in urine in pregnancy? Yes. Lactose. Fanconi syndrome? Yes. Galactosemia? Yes. So what is the right answer? 1 in multiple myeloma, it is not found. Okay. A person, this is the next question. A person gives a urine sample for a routine screening test. Benedict's test is positive. Below is the result of Barfoed's test. So do you see an image showing Barfoed's test? And in Barfoed's test, do you see any red color precipitate here? First tell me, what is Benedict's test and what is Barfoed's test? What is Benedict's and what is Barfoed's? Benedict's test is used to detect the presence of a reducing substance, whereas Barfoed's test is used to detect the presence of a monosaccharide. Reducing monosaccharide will answer Barfoed's test. Have you all memorized it? Benedict's test is answered by any reducing substance. Barfoed's test is answered only by reducing monosaccharides. And when it answers Barfoed's test, you will see a red color precipitate in the bottom. But here, do you see any red color precipitate? No, which means Barfoed's test is negative. Okay, if Barfoed's test is negative, which of the following is the most probable cause? Can anybody answer? If Barfoed's test is negative, it means it is a disaccharide. Yes or no? If Barfoed's test is negative, it means it's not a monosaccharide. If it's not a monosaccharide, what are the choices you will exclude? It is not diabetes, it is not Fanconi's, it is not galactosemia. But did I tell you in pregnancy the disaccharide lactose gets excreted? Yeah, if Barfoed's test is negative, all of you, have you understood it? If Barfoed's test is negative, it means you have excluded monosaccharides. It means it is a disaccharide, which is the only disaccharide that can be found in urine. It is lactose. If lactose is found in urine, then it is pregnancy or lactation. Clear? Yeah, so answer here is, so this is how it would be positive. Can you see that there is a red color precipitate, and if it's positive, it means it's a monosaccharide. If it is negative, it means it's a disaccharide. And one of the disaccharides which do not answer Barfoed's test is lactose. Okay. So this will be the last topic for today. So I told you these are all the pathological sugars that can be found in urine. So after you do Barfoed's test, if it happens to be positive, then you should find out whether it is glucose or fructose or galactose. To find out if it's glucose, then you do glucose oxidase peroxidase test. Do you understand this? If it's glucose, then you do glucose oxidase peroxidase test. It is nothing but the glucose strip that you use. How many of you have used glucose strip to detect if there is a reducing substance in the urine, if there is glucose in urine? Most of you would have done it, right? So that strip is based on glucose oxidase peroxidase. So if that is positive, then it is glucose. And to find out if it's fructose, for those of you who don't know this, glucose and galactose, all these are aldoses. Whereas fructose is a ketose. Yeah, fructose is a ketose. And only ketosis answer Selvinov's test. Only ketosis answer Selvinov's test, wherein you find a cherry red color. Selvinov's test, you will find a cherry red color. So if Selvinov's test is positive, it means it is fructose. Okay. And to find out if it's galactose, we do a mucic acid test. To find out if it's galactose, we do a mucic acid test. To find out if it's a pentose, I was telling you essential pentose urea. So pentose's answer Bial's test. Yeah, pentose's answer Bial's test. So can you all repeat this? Glucose answers glucose oxidase peroxidase. Fructose being a ketose answers Selvinov's test. Galactose answers mucic acid test. And finally pentose's answer Bial's test. Okay. Now answer this question. I will give you 30 seconds time. Read it. A person's urine answers Benedict's test. The biochemist runs a battery of urine tests to detect the reducing sugar present in urine. Based on the images provided below, find out the substances found in this urine. Yeah, Barfoot's test, glucose oxidase peroxidase, mucic acid test, Selvinov's test. What is your answer? Okay, I will help you. So tell me, is Barfoot's test positive or negative here? You see a red color precipitate. So Barfoot's test is positive, right? Very good, all of you. Good. So if Barfoot's test is positive, it means it's a monosaccharide. Okay, so it's not pregnancy or lactation. That is a monosaccharide. Glucose oxidase peroxidase is negative, which means it is not glucose. Yeah, which means it is not glucose. When it is not glucose, what are the choices you have excluded? It is not diabetes, it is not Fanconi syndrome. Mucic acid, this is the control, this is the urine. So mucic acid test is negative. When mucic acid test is negative, it is not galactosemia. Okay, and you see a cherry red color in Selvinov, which is positive. If Selvinov's test is positive, it is a ketose, which is fructose. So in which condition do you think fructose will be positive in urine? It is fructose urea. Do you all understand this? It is fructose urea. So are you clear about this? Yeah, I hope it's clear to all of you. So whenever Benedict's test is positive, you first perform Barfoot's test. If Barfoot's test is negative, it means it's lactose. It is pregnancy or lactation or some form of lactose urea. If Barfoot's test is positive, then some monosaccharide is found in the urine. What are the probable monosaccharides found in urine? Glucose, galactose, fructose and pentoses. To find out which sugar it is, first you do glucose oxidase peroxidase strip. If that is negative, you have excluded glucose, right? And then to detect if it's galactose, you do mucic acid test. That is negative, galactose is excluded. Selvinov's test is positive, then it is fructose. Clear? No, this class won't be deleted. It will be there on YouTube. Okay. So thank you all. I hope this session was helpful. So try to watch this again and recollect all the facts, because all these might look as if it's clear, but later on you might forget it. Okay. So all the best. See you tomorrow. See you tomorrow at the same time, 4 o'clock. So tomorrow I will be telling you few must know MCQs. Yeah.